Hello class, this is Dr. Anderson and this presentation is about the autonomic nervous system. So you see that I have a lot of learning objectives. My top one is somehow gotten away from the from where you can see it, but these series of questions are a lot of details about where the preganglionic neuron is, where the postganglionic neuron is, where are the receptors, where are the neurotransmitters, where are the integrating centers, what kind of receptors are these neurotransmitters binding to, and the like. So going through these questions would be a good idea. Then we're going to apply some details in terms of the function. So there's a big difference between the alpha 1 and the alpha 2s. Alpha 1s are the major vasoconstrictors. There are axonal synapses that involve alpha 2 receptors. Beta receptors are relaxing smooth muscle, while alpha 1 receptors are constricting smooth muscle. We also want to talk about the adrenal medulla acting like a postganglionic neuron, only it's a gland, and sympathetic versus parasympathetic tone, actions of each system, and some actions on the heart and respiratory system and whatnot. Alright, so here's your brain showing you your cranial nerves, and the ones in particular that we're interested in would be ocular motor right here. That's very important for pupil constriction. Then we have the facial nerve. Facial nerve is very important for operating the salivary glands. Glossopharyngeal, right here, important, some roles in swallowing. And then the vagus, cranial nerve number 10, the physiologist's favorite cranial nerve, having all kinds of motor actions on the lungs, on the heart, on the GI system, etc. Here's your spinal cord. So your thoracic and some lumbar dermatomes are where the sympathetic nervous system exit the central nervous system. Then we have some sacral nerves where the parasympathetics are as well. So this is the picture from Vander. So here you see the cranial nerves. So cranial nerve number 3 is going to the eye for pupillary constriction. The facial nerve influences crying, nasal secretions, salivary secretions. The glossopharyngeal is important for swallowing. The cranial nerve C going to the heart, to the lungs, to the GI system, going all over the place. Then here in the sympathetic nervous system, the preganglionics are exiting the spinal cord through the thoracic and a couple lumbar dermatomes, synapsing and ganglia along the spinal cord, and then we have a couple of prevertebral ganglia here, and then sending along postganglionics, pupil dilation, a dry mucousy saliva, speeding the heart rate, dilating the airways, inhibiting digestion, etc. and so forth. So spinal nerves exit the thoracic and lumbar dermatomes, and there are the sympathetic chain ganglia, whoops, not the change, but the chain ganglia, or the prevertebral ganglia. There's a short preganglionic and a long postganglionic, whereas the parasympathetics, the top and the bottom, the cranial and the sacral, the ganglia are on or near the target, so there's a long preganglionic with a short postganglionic. And then this is a picture from, I think this is from Totora and Grabowski. So again, we see the thoracic dermatomes, we see the cranial nerves, very nicely innervating ciliary ganglia to control the iris, facial nerve, nasal secretions and the lacrimal gland, some of the facial going to salivary glands, and hypoglossal, important for swallowing. Vagus is important for swallowing too, but it's working on the esophagus. And then we see sympathetics and parasympathetics innervating the same gland. That's a concept called dual innervation. So the sympathetics raise the heart rate, parasympathetics lower the heart rate. Sympathetics dilate airways, parasympathetics constrict the airways. Sympathetics inhibit digestion, parasympathetics stimulate digestion. So this shows this idea of a preganglionic neuron synapsing in a ganglion, that's gray matter in the peripheral nervous system, releasing acetylcholine binding to a nicotinic receptor on a cell body of a postganglionic neuron that then projects to the periphery. Most of the time with the sympathetics we're releasing norepinephrine. There's one exception with sweat glands, and then acetylcholine being released by the postganglionic parasympathetic. Whereas the somatic nervous system we talked about before, this alpha motor neuron is going all the way to the target, releasing acetylcholine binding to a nicotinic receptor. So this is a picture of the sympathetic chain ganglia along the spinal cord. This allows information to actually go up and down the spinal cord. So you see here's the cell body in the spinal cord leaving the ventral root. It can synapse in that same ganglion, or it could go up and down the spinal cord, or go out to some prevertebral ganglion. So there's a lot of options in the sympathetic nervous system. Another picture, this is the picture from Vander showing you those sympathetic chain ganglia. So in terms of neurotransmitters, acetylcholine is released in the ganglia, binds to a nicotinic receptor on the cell body of the postganglionic. The postganglionic releases norepinephrine, which binds to adrenergic receptors, which come in alpha and beta subtypes. Parasympathetic nervous system, acetylcholine released in the ganglion, binds to a nicotinic receptor. So this is the same in both nervous systems. But the postganglionic neuron releases acetylcholine, which binds to a muscarinic receptor on the target. And that's shown in this diagram here. Here's our preganglionic, acetylcholine to a nicotinic receptor, and then an adrenergic neuron releasing norepinephrine at the periphery. There is one exception. There's a postganglionic sympathetic acetylcholine at sweat glands for nervous sweating. Here's the parasympathetic, nicotinic receptors receiving acetylcholine in the ganglion, but at the target we have muscarinic receptors for acetylcholine. This is the picture from Vander describing the somatic nervous system versus the parasympathetic. See that long postganglionic, short postganglionic. And then here the preganglionic is shorter with a longer postganglionic, both using acetylcholine at the ganglion, but using acetylcholine versus norepinephrine at the effectors. And then here we have the adrenal medulla, which is going to release catecholamines into the blood. So here's a picture that I made. Here's our cranial parasympathetic going to the ganglion, a short postganglionic using muscarinic receptors at the target. Here's our thoracic sympathetic, short preganglionic, long postganglionic, releasing norepinephrine binding to the target tissue, adrenergic receptors, alpha or beta. Here's the adrenal medulla sitting on top of the kidney. This is going to release catecholamines, about 80% epinephrine, and then the other would be dopamine and norepinephrine. And then here are our sacral parasympathetic nerves. Again, a long preganglionic, short postganglionic, acetylcholine binding to nicotinic receptors in the ganglion, acetylcholine binding to muscarinic receptors at the target. So lots of things that are done. So for example, norepinephrine binds to an alpha-1 and causes the pupils to dilate. where acetylcholine binds to a muscarinic and causes the pupils to constrict. So there's a drug called atropine, which blocks muscarinic receptors, and that causes the pupil to dilate. You may have had that done at the eye doctor. Salivary glands, norepinephrine decreases secretions or causes thick mucousy saliva. Then we get all kinds of saliva with parasympathetic stimulation. Beta 1s at the SA node increase heart rate. Muscarinic at the SA node decreases heart rate. Sympathetics affect the myocardium. Notice there's the vagus, or the parasympathetics don't go to the myocardium. So there's no direct effect. Also on the blood vessels. The sympathetics regulate the blood vessels. In skeletal muscle beds, the blood vessels there have beta 2s, so you can get dilation for skeletal muscle in the fight or flight. So vasoconstriction over the whole body is maintaining the blood pressure, but with fight or flight we're still getting blood flow to the muscles through those beta 2 receptors. The innervation of the bronchioles, sympathetics dilate, parasympathetics constrict. Notice that GI regulation, parasympathetics promote motility and digestion. Sympathetics inhibit digestion and inhibit what do I want to say? Digestion. Sympathetics. Oh, my chart here is wrong. I tried to do my tabs and I didn't do it this right. Parasympathetics stimulate insulin. Sympathetics inhibit insulin. So I meant to bring that over to this column. Sympathetics promote lipolysis and of the fat tissue, relaxation of the uterus. So preterm labor drugs use sympathetic agonists, which is why moms worried about preterm labor, they're taking a drug and then that gives them an increased heart rate and makes them kind of nervous. Alrighty, so at rest, the heart rate is regulated by the vagus. So you have some runner that has a heart rate of 50, we'd say that person has a high vagal tone. But the vagus doesn't go to the blood vessels. So the sympathetics regulate vascular tone all the time. And so that's called sympathetic tone. And the nurse anesthetists know somebody goes into surgery, they get spinal anesthesia, what happens? Their blood pressure drops because you have inhibited the sympathetics. So an application of the autonomic nervous system is a condition called hyper-reflexia or dysreflexia. So we want to talk about what's going on with this condition. This happens in patients with spinal cord injuries, particularly in the thoracic dermatomes. And essentially, the shock of the injury, there's an inhibition of spinal cord activity, but as the person recovers and the spinal cord changes, it's going to form new synapses below the transection. And that causes a lot of activity below the lesion. And people can get something called a mass reflex. So let's say their bladder needs to be emptied, or they need to have a bowel movement. That stretching of the organs can send a bunch of action potentials to the spinal cord, activate sympathetic output, and then the blood pressure goes up like crazy. So massive sympathetic output below the lesion, and then above the lesion is parasympathetic. And why is that? Because the blood pressure is high. That stretches the baroreceptors, that activates the parasympathetic nervous system, and the person will get bradycardia. And then things like nasal congestion and flushing and a headache and that kind of thing. But what you're concerned about as a healthcare provider is the fact that this person's got unbelievable hypertension. And maybe it's sustained and maybe it's going back and forth, but that is what you're treating. So you'd help the person have a bowel movement. You'd help the person empty their bladder. If it's a spinal cord injured woman who's in labor, you would help her have the baby. You might give her spinal anesthesia, not because she needs it for the pain, but because you want to prevent a hyper-reflexia event. Somebody's having surgery and they start having an episode. You stop the surgery and help them with their hypertension. So this is not necessarily something you're going to see every day, but it's a great way to apply what your parasympathetic versus your sympathetic system is doing. All right, I guess that's my last slide, and we'll end it here, and I'll see you in class.